Okay, thank you everyone for taking the time to join us today from the Legislative Building in Regina. We'll have Saskatchewan's Chief Medical Health Officer, Dr. Saqib Shahab, SHA CEO Scott Livingstone, SHA Emergency Operations Chief Derek Miller. And just a note that copies of today's material are available at the bottom of today's cases news release, available on saskatchewan.ca. Start with Dr. Shahab.
So I'll maybe make a few opening remarks and just walk through some epidemiology and modeling slides that we do go over every 3 or 4 weeks. So again, I'll start by offering my condolences for the 2 residents who've passed away since we last spoke on Tuesday. And again, my condolences to family and friends. And with high numbers of people in hospital and ICU, we unfortunately will continue to see deaths due to COVID-19, which is very tragic. And that really is why we all need to continue to work together to draw our community transmission rates down. Do everything we were doing in December, reduce our movements, stay home as much as possible, take all precautions like wearing our mask when outdoors, staying home if you have even mild symptoms, and washing hands frequently. There's hardly any influenza going around in Canada, so if you have any respiratory symptoms, do the right thing, stay at home, get tested, and if your test is positive, make sure that you let public health know who your close contacts are. It will be well into the spring since we will see the impact of vaccines having impact on our total number of cases. So while it's really great that vaccination started, we really have to stay the course with our public health measures. If we continue to see, this week has been up and down, 250, 300, 400, 300 again. So if we continue to see cases as high as this week, I will be speaking to the Minister of Health, Mr. Merriman, about additional measures which may be required next week. And this is really a critical time for us to really try to bring our numbers down just the way we did in December. So if you look at our EPI update, again, the EPI tells us what happened in the past, and modeling can't predict what will happen in the future, but it tries to project what we can expect to see given various scenarios. So I won't spend a lot of time on all the slides. A lot of the information actually is on our dashboard. So obviously, our case numbers have been going up. And right now we are the highest in Canada in terms of our active cases, and we are also the second highest in Canada in terms of our average cases over the last 7 days. So again, this is a critical time for us. We have done really well so far, especially up to November. November we saw cases escalating. In mid-December, we were able to plateau and have a reasonable holiday season. But now we have seen, again, a significant escalation and really have to pull together to address this. And then, there's always a 1 to 2 week lag, but our hospitalizations and ICU admissions have been the highest they've ever been. And while many of us had some time off over the holidays, our colleagues in the healthcare system have been working flat out throughout November, December, and again, the trends are very concerning. We have ample testing capacity, and our testing did dip a bit over the holidays. That partly explained the lower case numbers. We have ample testing capacity, and again, if you have any symptoms or any concerns, please seek testing. It's essential to stay at home if you have any symptoms or concerns, seek testing, and then isolate for the 10 days if you're COVID positive, and make sure your close contacts are informed, and then they can isolate, because this is the tried and true method of addressing chains of transmission. And again, we talked a lot about in the early days of the pandemic about looking out for each other. Many people who are getting COVID right now, in some cases, have challenges isolating at home. They may be on their own. They may be living in clouded conditions. And so, again, if you have friends and family who want reach out for help, please support people to isolate safely at home. You can fetch groceries and drop them at the doorstep. A lot of that community spirit was apparent, in the early part of the pandemic. We really need to support each other in that way. And of course, if individuals need assistance with isolating, public health and social services and other agencies are there to support individuals who may have difficulty isolating at home. This shows a bit of a detailed summary of, by the various geographic areas of our daily new cases, which remain high. Our case rate per 100,000 is 26, again, very high. We should really aim to go below 10. And, it is very high in different parts of the province, but with smaller populations, it can fluctuate quite a bit. And our active case numbers are very high. Our test positivity, again, can fluctuate quite a bit. Average is 12. But as you can see, it fluctuates anywhere from 6 to 30. So again, it's very concerning. So in the smaller geographies, it can fluctuate quite a bit. But overall, the fact that our test positivity is around 12% is very concerning. Really want that to go down to below 5% as well. And our testing numbers have been picking up, so that's very reassuring. And again, I would urge everyone with any concerns to seek testing, even if you think your symptoms are mild, because that's essential to break the chains of transmission. The further slides just show trend lines that they have been trending up in terms of our daily average case numbers and test positivity. This slide is also important. This really shows cases by the various geographies. And again, we have COVID activity throughout the province, but certainly higher in the north and far north. Saskatchewan, Regina came down over the holidays, picking up a bit again. A bit quieter in the central part of the province, and a bit quieter in the south, but again, it did pick up in the southeast. So again, we have information by 32 geographies on our website. So again, depending on where you live, it's useful to look at that, but we have to remember, even if our case rates are low where we live, we have to follow exactly the same precautions. Case numbers can go up very quickly, but if you all take the right measures, they can also come down very quickly. We have to remember that over the past year, we have seen 750 hospitalizations in every age group, and 164 admissions to ICU, and more than 200 deaths. So again, this has not been a minor event by any stretch of the imagination. We have had significant hospitalizations in hospital and ICU and deaths, and of course, a large number of people who have been quite sick while isolating at home, and some have had milder symptoms. Our case numbers compared to Canada, our mortality rate has been lower, but again, the last two months we have had outbreaks in long-term care facilities, and that is increasing our mortality rate as well. And if you look at our current hospitalizations, again, we have hospitalizations in every age range, but certainly they increase 40 to 59, 60 to 79, and then 80 plus. We recognize that this doesn't capture all persons, because if you are in a long-term care facility, you may continue to be cared there. And similarly, ICU cases remain high, especially 40 and older. So, and again, the 80 plus is not accurately captured, because in many cases, individuals may continue to be cared depending on the care directives in the long-term care setting. I'm not going to spend a lot of time on this, but certainly, when we look at exposures, over the time we've seen a lot of, so the right column shows total from when the pandemic started, and on the left column, the middle column, it's from over the last week. Obviously, international travel is not accounting for a lot of our cases. Interprovincial travel is, and we have to really not travel unless absolutely essential. And we see, transmission in healthcare settings and workplaces, but primarily it is household exposure, and then in other public and other social settings. And then when we look at outbreaks, we have seen a decline in large super spreader events. But having said that, even when we look at smaller clusters, they continue to happen in all public settings, workplaces, other public settings, as well as social settings. Even though we're not supposed to be meeting between households, we continue to see transmission when people have gotten together over the holidays. One thing that is very positive is that our number of contacts has come down, and our mean number of contacts is 4. It was as high as 8 in the middle of November. That has really come down, and our range of contacts for close contacts is 1 to 35. For all contacts is 1 to 75. It has been as high as 200 in the past. So obviously this means that we're not having large gatherings. Worship services are capped at 10. Receptions without food are capped at 10. So that is positive, and we really need to again stay the course. We should be able to. I used to say that we used to be able to count our contacts on the fingers of 2 hands. Now really we should be able to count our close contacts on 1 hand. And really that is what it appears the bulk of the population is doing. So it's not like we're not all trying hard, but I think we just need to try that a little bit harder as we did in December. Be very thoughtful about where we go, what we do. Are we using all the precautions at our disposal to minimize transmission, even in settings where you can go, like retail, or if you choose to go to a restaurant. But again, order more takeouts, support your favorite businesses, but order more takeout, when you shop, try to do curbside pickup, go when it's less crowded, do all these measures to reduce, the traffic and the crowding in public places. And finally, a few slides about modeling. And again, we're fortunate to have a very, experienced modeling team in Saskatchewan. And what they have been showing us, if you see the black line, this is the actual case numbers. And then the blue bars are what we expect to see if we comply with public health measures. And the pink bars, what we expect to see if we have poor compliance. So again, our case numbers are trending up, which is very concerning. And according to the modeling, they could go as high as 800 or come down to below 200. But currently, they are trending up. We would like that black bar to start trending down. And the other concerning thing is that the modeling in December was saying that with the same measures, we could have our trend go down. The blue at that time was going downwards. Right now, the modeling is saying that with our current measures, actually, our numbers, we'll be lucky to maintain the status quo. It's not trending down. And I think that's something we really need to think about in terms of what can we all do to push the curve down and what further measures are required to further, reduce transmission. And the pink bar, of course, shows that if we don't all adhere to these measures, if even 5% or 10% of us aren't adhering to these measures, that we can very easily get into the red situation, which could be 1,500, 1,600 cases a day, which is absolutely not where we want to go. And similarly, with a 1 to 2 week lag, we can see the impact on hospitalizations. Again, the upper limit of the blue bar is not something we want to see, and certainly the red bar, which shows hospitalizations, which can be much higher, is absolutely a direction where we don't want to go. And same is with ICU admissions. And we have to remember that, if we all pull together, we can turn our daily case numbers down within 1 to 2 weeks. But hospitalization, ICU admissions can be anywhere from 3 to 4 weeks or longer. So even though the numbers come down, the pressure on the acute care system continues for many weeks longer. So with that, I'll maybe close this section of the presentation and just reiterate that we actually know all the measures. We mask use, physical distancing, reduce close contacts, reduce non-essential travel, work from home, and stay home as much as possible. With great mild weather, yesterday and today accepting, take full advantage of the outdoors, hand sanitization. And, we've had minor updates to the Reopen Saskatchewan guidelines. Please be familiar with the guidelines. We did a review of bars, restaurants, other settings. For the most part, people are complying, but in some instances, there's lack of compliance with mask use, there's lack of compliance with 4 people at a table. It's not fair for business owners to always have to say to patrons, what the guidelines are and how to observe them. It's not fair to them. And we should all be knowledgeable about the guidelines and follow them to a dot. That is the only chance we have, or a week or two. Otherwise, it could lead to further severe restrictions, and that always has significant consequences. I'll just see if I have any other points further to the presentation. And Yeah, no, I think the only other point, we did get some questions about, are there other respiratory viruses going around? So again, right now, we need to take every minor cough, scratch in the throat as COVID unless proven otherwise. And so again, we are not seeing any influenza virtually, and that's because of all the measures we're taking. But influenza is easier to prevent than COVID. So again, I'll just reinforce that, please make sure that you stay at home if you're unwell, and seek testing and follow all the measures that we should all be familiar with. Thank you.
Thank you, Dr. Shahab. Scott Livingstone.
Thanks, Matt. Good afternoon, everyone. Joining us, just as a reminder, is Mr. Derek Miller, the Saskatchewan Health Authority Emergency Operations Chief. He's on the line with us, and Derek is going to give us a presentation in a few minutes on the COVID immunization campaign and our delivery plan. Sadly and sincerely, like Dr. Shahab, I'd like to also acknowledge the loved ones, friends, and family of those who've passed recently from COVID-19. And again, for those who are wavering about the continued need for strong measures to fight COVID-19, this should be a stark reminder about the consequences of this deadly virus. Given our continued surge in case numbers, I'd also like to urge all of you to thank our healthcare workers. They are working tirelessly without breaks throughout the pandemic Christmas season to care for our patients, residents, and loved ones, and at the same time now support our immunization program provincially. I'd like to acknowledge, with respect to our immunization program, we continue to strengthen our vaccine rollout. In the early going of the pilots, our processes and looking at delivery to remote northern areas, this did slow us down a little bit. We needed these phases of work to get a better handle on the logistics and how we would best and most efficiently distribute the vaccine to those of highest need. We're encouraged recently in how we've been able to learn from those early phases, and we're seeing encouraging signs of a growing number and a pace of delivery for the vaccines across our province. Speed does matter, especially among our vulnerable population where it saves lives. This is why we need to continually get faster in what we're doing and expand our program as vaccines become available to us here provincially. With that, I'm going to ask Derek to give us a status update on our immunization campaign and delivery plan. So go ahead, Derek.
Thank you, Scott, and good afternoon. I'm pleased to provide an update today on our COVID-19 immunization campaign and delivery plan. A few things that I'm going to touch on today include the goals of our immunization campaign, the phase 1 priority groups that have been established. We'll also provide an update on our progress to date, and then cover off our 3 key strategies for the campaign, including faster, smarter, safe, and then wrap up with a few key messages and next steps. Our immunization campaign goals include minimizing serious illness and death, protecting those that are most vulnerable, protecting our healthcare capacity, minimizing spread, and also protecting our critical infrastructure. These really guide us in what we're trying to achieve with our overall campaign. The supply limitations that are being experienced for the COVID-19 vaccine require us to take a very diligent approach to sequencing the vaccine rollout. And in order to achieve that, we need to establish priority populations to guide those sequencing decisions. In Saskatchewan, the priority groups are consistent with advice provided by the National Advisory Committee on Immunization recommendations for the COVID-19 vaccine. We have an oversight structure where a joint committee provides approval for the priority populations. And this is based on advice and recommendations coming from an advisory committee of clinical and ethical experts. So within our phase 1 priority population, there's approximately 190,000 people in that group. And based on the federal allocations that have been identified so far, going out to the end of March this year, we will have enough vaccines to vaccinate approximately 50% of this group, leaving us short about half, obviously, of immunizing all of the high priority populations that have been approved in this framework. An update on our progress to date. Yesterday, we delivered 1,393 doses of vaccine, our highest in a single day yet, and that is despite a significant weather event that impacted many locations across the province. We are continuing to build on this capacity as federal allocations to Saskatchewan increases in the coming weeks. Our 7-day average is just over 1,000 doses delivered per day. With the early experiences with the pilot and rollout so far, we are continuing to improve on our capacity and ability to quickly deliver vaccines and meet the allocations that we're receiving. In fact, we anticipate as we continue to ramp up the doses delivered per day that we will experience shortages going forward, and even in the coming week, we may run out before the next allocation. And based on our target of the speed of delivery, we do expect that over the coming weeks and months that we will go through periods of having an allocation arrive and then working to deliver it as quickly as possible, and then basically wait for the arrival of the next delivery. We have 3 key planks to our strategies as part of our vaccine campaign. The first one is faster. Speed really matters in this. Every day counts to save lives and reduce the overall impact of COVID-19. A number of key aspects of this strategy to deliver vaccines quickly include a hub model. We are establishing distribution hubs across the province, over 20 locations that will be a distribution hub for different types of vaccines, so Pfizer and Moderna at this point. We're adopting an all-hands-on-deck approach to delivery, leveraging all of our appropriate healthcare providers that can deliver vaccines, as well as looking for and seeking support from external resources to really bring all resources to bear as part of this strategy. We're continuing to support and strengthen a strategy to use mobile immunization teams to get into certain locations such as long-term care centers or personal care homes. Locally, we are testing different delivery methods in order to learn about how to provide vaccinations to priority populations, and also assess how we can scale up those different delivery methods to look forward to immunizing the broader population. Looking into the future, being able to forecast vaccine distribution with more accuracy will help us be more prepared for rapid distribution. And we know that a stable, predictable, and large volume allocations will really enable us for a rapid delivery. And lastly, and this is so important for us, is we are ensuring that all areas of our province, every corner is ready, that we have a posture of readiness, so that when we receive allocations of vaccine, that we can quickly administer it safely to the populations in those areas. The second plank of our strategy is smarter. Learning matters. Continuous improvement is already resulting in more rapid delivery, and we can see that just by the results over the last week or two. The health system is very experienced in delivering the influenza vaccine and other vaccinations, and we're gonna leverage that as we go forward, because we know how to do this. However, we also recognize that this is different, and there are pretty significant differences that are impacting this campaign. We do have limited, variable, and unpredictable allocations. They vary from week to week, and the timing varies as well. We need to sequence priority populations based on that. We're not able to just offer a mass immunization right off the start. We are managing multiple different vaccines that have different logistical handling and delivery requirements, and which creates complexity, and also dealing with the various transportation and distribution challenges that arise in a province of geographically dispersed like Saskatchewan. We are looking at and learning from the improvements that were made following the initial pilot in Regina and the early phases of the rollout of vaccine. Improvements include the transportation changes that allowed us to move the vaccines in a more efficient manner. We're leaning on our local teams who, again, they know how to deliver vaccines and how to conduct a campaign to come up with new and creative and innovative delivery methods. that leverage the breadth of potential providers that are in the different communities and will help us be successful. And also, as a single health authority, we're in a really strong position to learn from each other as we continuously roll this out and we plan for phase 2 and looking towards a mass immunization for the general public, and how are we going to best scale up to be ready for that. And finally, we're learning from our partners. We are working with our stakeholders in the planning and delivery of the vaccine, including First Nations and Métis partners and community-based organizations and others. Faster, smarter, and safe. Safety matters. High uptake requires strong communications to ensure the public knows the vaccine is safe. We know the COVID vaccine is safe. It is Health Canada approved and has gone through the various regulatory reviews and approval processes. We also know that it's effective, over 90% effective in reducing the risk of infection. And it's simple. It's just like getting a flu shot for Saskatchewan residents. Our healthcare workers are highly experienced and have many years of successfully delivering flu vaccine to the residents of Saskatchewan and ensuring that all safety requirements are achieved. And we know that we have a very committed workforce that's going to support the safe delivery of the vaccine. The World Health Organization estimates that vaccines save 2 to 3 million lives in a normal year, and this isn't a normal year, so we will be saving many more with the rollout of the COVID-19 vaccine. It also lists vaccine hesitancy as one of the top 10 global health risks, and this just brings us back to why safety matters. We need to ensure a strong communication approach so that the public knows that the vaccine is safe. Key challenges that we are encountering and planning and working through. The first one, delivering to high-risk populations in remote areas and slow the pace of delivery. Again, geographically dispersed, it does create logistical challenges that impacts speed of delivery. Pfizer is more logistically challenging based on the sub-zero requirements and handling needs, which makes it difficult to get them into some of the rural and remote locations, creating a limitation on us. Various administrative processes like the consent process in long-term care environments and personal care homes is time intensive. Also, high volume booking processes need to be established. The vaccine to people living in communities. We are going to be and currently dealing with limited, variable, and unpredictable allocations, and we hope to see this resolve in the coming weeks as more is known about our supply chain for the COVID-19 vaccine. And we live in Saskatchewan, so adverse weather may cause transportation challenges and other difficulties, especially in some of the rural and remote settings, but also even in our urban centers. And we experienced this yesterday and even today. It has an impact. And lastly, I'll just highlight the resource constraints that we're feeling with our ongoing pandemic response in our other areas, on our offensive and our defensive strategies. We, and Dr. Shahab spoke extensively about the ongoing high COVID cases and the impact that has on our system, both in terms of contact tracing, outbreak investigations, and so on, but then also in our acute facilities through hospitalizations in acute beds as well as our ICU. And I'll just point out that today we hit our I guess our highest COVID patients in hospital so far through this at 206 COVID patients, which has an ongoing strain on our resources. Key next steps. We will continue the rollout of vaccines to those priority sequence populations, many of which are ongoing now in Saskatoon, Regina, Prince Albert, Moose Jaw, as well as other areas in the north and rural areas of the province. Those are well in progress. We have started just recently rolling out by appointment clinics for ages 70 plus in a number of communities in the north. And that reflects the success actually in rolling out vaccines to others that are in that priority 1 group in those areas. Localized rollout is determined through a combination of risk criteria for priority populations, logistical factors, and availability of supply. So again, this speaks to the complexity of this campaign. And we are prioritizing based on the epidemiology that Dr. Shahab indicated. We also have priority populations that we are focusing on, and then just the plain logistical challenges of moving and delivering the vaccine across the province. And then of course, the availability of supply, which is which varies. So this is going to result in some areas, like we have the communities in the north that have been identified here, where they're providing vaccines to people living in the community. And then in other areas of the province, they may not have started vaccination yet. And this is it is going to vary across the province just based on these factors. We really appreciate the patience of Saskatchewan residents that want to get the vaccine. And that's really really positive news in terms of achieving a high level of vaccination across the province going forward. But we do know that there is going to be variation in the coming weeks and months ahead as we roll out this campaign. And just another note, our speed of delivery, it may be impacted by weather, as we're seeing in the moment. Other key next steps that we're working on, we know again that we're not getting all of the vaccine we need in one batch delivery. We're going to get it spread over weeks and months. And so based on that, we do need to establish prioritization of groups that support us in sequencing the delivery of vaccine to those groups based on the supplies as they become available. And that will continue through the phase 1 that we're in right now and on into phase 2. At the same time, we are preparing for widespread immunization in phase 2, where we will open up access to the general population and conduct Saskatchewan's largest ever immunization campaign. One of our key tasks is to ensure that our teams are ready to deliver the vaccine as soon as possible on arrival and enhance speed of delivery. And this is true in phase 1 as we're focusing on those priority populations, and it will also be true when we go into phase 2 and get to the point where we're vaccinating the general public. Key messages that I'll touch on: the safety of our patients, our residents, and our healthcare workers. It remains our #1 priority with our vaccination campaign, as well as our entire pandemic response. Speed matters, and that is why we need to continually get faster and smarter in our delivery. Stable, predictable, and large volume allocations will make this rapid delivery model easier and make us more successful. And just lastly, and again, recognizing Dr. Shahab's earlier comments, currently our health system is at its most fragile point yet, with our highest hospitalization rate and a high case count. We need the public to support us in remaining vigilant, abiding by the public health orders and other guidance from public health in order to get us through this. Our health system is adopting an all hands on deck in order to get the vaccine rolled out provincially as quickly as possible. And we need the Saskatchewan public to be all hands on deck in containing the spread of the virus. I'll turn it back to Scott.
Thanks, Derek. Just before we turn it over for questions, I want to reemphasize some things that Derek spoke to. And certainly, as Derek pointed out, at times we may have some overlap in our allocations where we have some number of small doses in the freezers, but that's because of the new ability to transfer the Pfizer vaccine in particular into other locations. We want to make sure we're getting the vaccine out as quickly as we can to those vulnerable populations and get vaccine in arm as quickly as possible. So it won't be in the freezers long. As the vaccines come in, we will get them out and they will go and get administered as fast as we can in the arms of those who need it the very most. We it's so important at this phase in the vaccination program to look at the big picture and how, you know, the limited supplies are also limiting some of our capabilities with respect to how broadly we can go with the vaccines, but we are focusing on our most vulnerable. Our Clinical Expert Advisory Committee has designated the populations that are high priority, together with Dr. Shahab and also the National Advisory Council on Immunization stated goals for the program and the criteria for priority populations. So in other words, the federal definition of what groups are most critical to vaccinate as soon as possible. Currently, the planned federal allocations for phase 1 will leave us approximately 50% short of fully immunizing our high priority populations in phase 1. And there are two reasons for me to making this clear for you guys, is that supplies are limited, so we need patients from those who are not among the priority populations. Serving our most vulnerable population will save lives, so please be patient with us as we ensure that they're served first. Secondly, we know that with a stable, predictable, and large volume allocations that we can plan far in advance and make delivery across this province much more rapid. Having to micro-target our vulnerable populations across such a wide dispersed province like Saskatchewan is so important, but it also leads us to some inefficiencies, as Derek pointed out. We know that we can build economies of scale if we can leverage large, consistent supplies. Most important thing to remember is that this only marks the beginning of the end and not the end itself. We still have a long way to go, as Dr. Shahab has pointed out. And as Derek has said already, our healthcare system is at its most fragile point during the pandemic. And our continued success in supporting both our offensive strategy, contact tracing, testing, and assessment, our defensive strategy, and ensuring we have hospital capacity for those that need it, both COVID and non-COVID. Again, adding to that is our dealing with outbreaks across acute care, long-term care, and other facilities across this province. And last but not least, and most importantly, in some ways, is our ability to support a widespread, smart, fast immunization program. This is why we need the public more than ever to double down on their efforts to help support the system to be able to deliver for the people of this province. And with that, I'll turn it over for questions.
We'll take time for questions in the room here. Arthur?
This is for Scott and possibly also Derek. I've just heard that you had to repurpose space for ICU capacity recently, that because of the high numbers, there's been certain areas that have been repurposed. Can you just tell me about how you manage that, like what units ICUs have moved into, how you found the staff to accommodate the beds, and how much further that can go if we continue to see growing hospitalization?
Sure. Good question, Arthur, and I'll start, then if Derek has some things to add, I will. So just to start off, with respect to the repurposing of space, and it's not just one space. So I'll use Regina as an example, as Regina has multiple units that care for high acuity patients, whether it's a surgical ICU, cardiac care unit, regular ICU, and then a medical ICU. So there's flexibility in that and how we use those beds and repurpose them for both critical care patients that are COVID and non-COVID. In Saskatoon, as you know, not just in Saskatoon, but when we started the planning for the pandemic, a big part of it is how we build ICU capacity across the province and repurpose not just space, but ensuring that we have the right equipment and supplies to do that as we expand, and the trained staff to do that. So we've been working through since the start of the pandemic on doing that, upskilling physicians, upskilling nurses, tracking down nursing staff and trained staff in ICU that may have moved on to other areas of care, so that when we need them, we can redeploy them. So that's part of what we've been doing. With respect to how much farther we can go, so you've heard some numbers. We've been asked lots of questions about where we are with ICU capacity in the province, and we're sitting at about 95%. That's COVID and non-COVID patients. And we know that we can double that capacity with the work that we've already done to ensure that we have the right equipment, redeploying staff to different space. In Saskatoon, essentially we repurposed the old pediatric intensive care and built another adult ICU in Saskatoon, so that increased our capacity as well. And again, one of our challenges, and Derek touched on this, and Dr. Shahab talked about it a little bit, is the importance of us being able to take the labor pool and the staff and move that in there. And that is going to be one of the bigger challenges, is with all the other pressures the system is experiencing, both on the offensive side and the defensive side, and now with immunization and helping to manage outbreaks, we're pushing ourselves to the absolute limit. And like I said, that we're at the most fragile point we've ever been in the pandemic.
Arthur?
is for Dr. Shahab. You said today that you should assume everything is, COVID until proven otherwise. What is the current rate of asymptomatic transmission in the province, as far as you know? Could you provide us some more detail on that?
Yeah, so this is a really critical point to understand. So our modeling colleagues estimate, that we have X number of active cases, and then they calculate a number that they use for the modeling assumptions. That's called the undiagnosed infectives, and that can be anywhere as high as 2% of the population. So if you have 100 people sitting or walking around, 1 or 2 out of that 100 may be shedding COVID and not be aware of it. Because we know in younger adults especially, 40% of COVID infections can be asymptomatic. So I think that is exactly why we are behaving as we are. If COVID only transmitted when you were sick, it would have been as easy to control as SARS was. Because there you transmitted only when you were sick, you isolated, it went away. COVID is more challenging because in 40% of cases, it transmits in people who don't even know they're sick. So we have to do everything we're doing right now because none of us would come here if we were sick, but we could still be transmitting. And secondly, even for people who get unwell, the peak transmission of COVID is 2 days before the start of symptoms, and for 4 or 5 days after the start of symptoms. And by day 10, most people are not infectious. So I think that is the challenge, and that is why all of us need to observe these measures all the time. But of course, if you are symptomatic, you need to stay home, seek testing, and then testing allows you to notify your close contacts, because that is also an important way of breaking the chain of transmission. These measures all the time, and then seeking testing so that close contacts can isolate as an additional layer are key. And I'll just add that, of all the tests, our test positive rate is around 12%. And the provincial labs do track how many proportion of tests are in asymptomatic people. And asymptomatic people may seek testing because they're a close contact, they're part of an outbreak, various reasons. And as we expect, the test positive rate in asymptomatic people can be 3-4%. So it's not low. Previously, it was much lower. Previously, our overall test positive, if you recall, all the way till September, October was less than 1%, then went to 2%, and asymptomatic is much lower than 1%. Now, in asymptomatic is 3%, so that kind of speaks to the undiagnosed infectives. That's why even gathering between households is so challenging, because if 20 households decide to gather, meaning 100 people, at least 2 households will result in transmission. So that's the challenge. And so I think that's a really important concept that we really need to take to heart about how to bend the curve, that we should, consider all of us as potentially infectious. That's how we should behave outside our house.
Take our next question. Mark?
Dr. Shahab, last press conference, after the last press conference, there was protesters following you to your vehicle. What was your reaction to that, and have you felt unsecure at any point during this pandemic?
So, I personally feel fine, and obviously I rely on law enforcement and all the other measures in place in society to protect me like everyone else. But, having said that, it's only a small number of people. But again, I actually am concerned and feel a bit sad that why would people not believe the basic evidence? We're not talking about having a debate over is this policy better than that policy. We can debate all those things and should debate them. But the science is very clear. So again, that would be my concern, that, if anyone has any concerns, go to credible websites. There's so much information out there that, again, speaks to, how significant the pandemic is in terms of hospitalizations and deaths. These are real people who unfortunately have been in hospital, are suffering long-term consequences and have passed away. There's evidence now about how all these layers that we talked about, mask use, physical distancing, staying home when you're sick, are critical, and how effective and safe vaccines are. And I think I really urge anyone with questions to go to credible sources to increase their understanding. And most of us already know the basics and are practicing that.
Follow up, Mark?
In your modeling presentation, you talked about the high rates that we're seeing in northern Saskatchewan. How concerning is that, and what maybe is fueling those high numbers that we're seeing there compared to in southern Saskatchewan?
Yeah, so medical health officers and communicable disease staff, nurses, and epidemiologists and public inspectors. They, investigate cases and engage in contact tracing and outbreak investigations. At a basic level, secondary transmission in the household is the number one transmission. So if you have a larger household and are living in crowded conditions, the risk of secondary transmission is higher. So 3 people living in a 5-room house, you may have no secondary transmission. 10 people in a 2-room apartment, you may have 4, 5, or 10 secondary cases. So again, seeking assistance and support if it's hard to isolate within your house is critical, and there are agencies, social services, public health who can support you in that setting. And then again, the second common source of transmission is gatherings in the house with people outside your household. And again, because we can be asymptomatic over the holidays, we saw even where you could as a single adult meet someone, we saw transmission happening even in those settings. And out of every 20 gatherings, 1 resulted in transmission because of our 1 to 2% positivity rate of COVID at any given time. So I think those are the primary drivers. But then, of course, we've seen sporadic outbreaks in bars and restaurants, not so much in gyms right now, but the updated guidelines that even slow things down further and spread things out more in restaurants, bars, gyms have helped. But even then, the guidelines are there. But if people insist on pulling tables together or not wearing a mask and argue with the business owners, that doesn't help. And those kind of situations create increased risk of transmission.
We'll take a question from the phones.
We have Lisa Schick with CJME.
Hi. I am wondering, what are the implications of being 50% short on vaccine doses for everyone in the high priority group? Does that mean you're going to have to be more selective? Are you trying other avenues to get more vaccine? Does that mean that the second phase will happen later than first thought?
Yeah, maybe I'll make some initial comments and then Scott and Derek can add. But we have to remember that we need 2 doses, and those doses should be given ideally within 42 days. Initially we were very strict with 3 weeks for Pfizer, 4 weeks for Moderna, but now NACI has recommended within 42 days. So we have to recognize that everyone who gets a dose in January needs a second dose 4 weeks later, possibly end January, early February. Everyone who gets vaccinated in February, they will likely be completing their program either end of February but early in March. And then by March, as allocations increase, other sequence groups will start getting vaccinated. So it is, you still have to complete your second dose before you, while at the same time you can able to start the next sequence group by March.
And so just to follow up, and Dr. Shahab knows this as well, as we've been working both with the Ministry of Health and with our Minister's office and Premier's office to like every other jurisdiction in the country, to access more vaccine and to create a more stable and predictable number for us to plan around so that we can be more efficient and faster.
Follow up, Lisa?
Yeah, sorry. So does that mean that there are no implications? Like the slide, I guess, says that you're going to be 50% short in having vaccinations for, or doses for the high priority group. So does that not going to have an effect on the plan or anything?
I'd like to say the plan will continue, but the completion of the second doses in some cases may be happening in March. For those who are sequenced first, the second doses may still be happening in March, but then by March, you could be starting with the next sequence group. But once you can see that everyone who's in the first priority group has completed first doses, the second dose may continue into March, but then you will be able to start first doses for other priority groups at that time.
And it speaks more to the predictability of you understanding what type of numbers we're going to be getting later on in the year to support the program. But it's really around that second dose is why that 50% number is we need to finish up as we continue to vaccinate high priority. So with respect to, does that change the program now? No. Well, vaccines coming in, and we're getting as many first doses in as many individuals in that vulnerable group as possible, and as quickly and as safely as we can.
One thing I'll just add, maybe I've heard that uptake in long-term care residents has been extremely high, and that's great. So high uptake is great. It puts more pressure on the supply, but that's what we want to see. We want to see high uptake in the most vulnerable.
We'll go back to the room. Steph?
Yeah, Dr. Shahab, what options are you looking at in terms of further health measures if we are really close to maybe having to go there?
So, even as recently as this morning, I had a detailed discussion with my counterparts in other provinces, and within the Ministry of Health, we maintain a detailed database of what are the exposures we are seeing. I talk to my medical health officer colleagues several times a week and take their recommendations. And then we look at our epidemiological data. We look at all the measures different provinces had, including us, and how they've changed. So at this point, I think it's hard to say that, okay, if you just do this one thing, it'll drive numbers down. It's not that. I think if we look at maybe 300 cases a day, certainly, we know that going out shopping, observing all the guidelines is less risky. We don't know how many cases that generates in a day, maybe 5, maybe 10, maybe less than that. But if all of us follow the guidelines, go when it's less crowded, go once a week, one person in the household, we bring that down. Similarly with bars and restaurants. Does that generate 30 cases a day? Because we don't know unless there's an outbreak, or unless in the last 2 weeks you only went to once outside and you went to a specific location, then you can say, okay, that was the exposure. But if someone went to 10 different places over 2 weeks, you can't really say where the exposure happened. So that's the other challenge. But again, slowing things down, following the guidelines, you try to reduce the exposure from the settings. And of course, the other option is that hammer approach, that you close everything down. Obviously, you see a reduction, but then there's a significant impact, social, economic, mental health, and so forth. But again, the bulk of the transmission seems to be right now social connections among individuals. Even outdoors, we can meet up to groups of 10, but if you're handing things back, that results in transmission. That's what's causing transmission. You have to maintain your physical distance, even while you're meeting and greeting others outside. Any interaction from anyone outside your household in the house is high risk. Obviously, if someone comes in to provide care or do other work, everyone's wearing a mask, maintaining physical distancing. But it's on the social interactions at workplaces, in the house, those are the highest risk settings. And then I did say that, we have individuals who really need support from public health, from social services, from friends and communities, because to be able to isolate at home, you need friends and family, if people reach out to support you, to get your grocery shopping, to look after your other needs in a safe manner, leave your groceries outdoors. So I think that community support is going to be really important now when it's required, and when individuals, and I would again encourage individuals to really reach out to public health for or social services support, reach out to friends and family. COVID is nobody's fault. It's nothing to be ashamed of. If you need support to help you isolate safely, reach out to friends and family.
Mr. Livingstone, you say 95% of ICU, there's 95% ICU capacity, COVID, non-COVID patients. Can you provide, at this point, what is the number of ICU beds we have in Saskatchewan? Because 95% of what, really? So how many ICU beds?
So on a regular daily basis, and it fluctuates, and it always does, whether it's COVID or non-COVID, we have the ability to flex capacity, but it's 75, and we're at 95% capacity, and about 34% of the current ICU beds are taken up with COVID patients. And as I said before to Arthur's question, we do have the capacity to double that if we need to, through the work that we've been doing for upskilling, reconfiguring spaces, and having staff on standby.
So I know in the past the figure for Saskatoon had been 23. Is it higher than 23 now for ICU beds? Is that number increased?
It's something I don't know the number off, but we can follow up right after and get you the exact number. You're welcome.
Take our next question on the phones.
We have Zach Viceras with the Star Phoenix.
Hi there, Dr. Shahab. I have a follow-up question in regards to what you said about asymptomatic transmission. Given that the number of contacts per person, the average number of contacts, seems to have declined, but also given this high rate of asymptomatic transmission, how much do we actually know about where exactly people are getting sick in Saskatchewan, where people are catching COVID-19? Are we able to make an assessment of that? And if no, how close are you to considering that hammer option, where you just like to limit as much activity as you can?
Yeah, so that is exactly the challenge, because if you look at 300 cases a day, about 150 of them are secondary cases to known cases. So 150 of them are household contacts of a known case, and they are already isolating. So the chain of infection breaks there. And then, you have maybe 30, 40 who say, you know what, I stayed home all the time, but this one time I went X place, and then most likely that is a source of transmission. So that populates our, 20% of the transmissions we can explain. And then, of course, if there's an outbreak, if 5 people say they went to this location, and that's an outbreak, and that's obviously, publicly disclosed. But beyond that, it is very challenging, because if you're staying home, you're not really getting exposed unless someone comes from outside to your house. But if you're out and about, and it takes up to 14 days for it to present, but usually within a week after exposure you are symptomatic. So even if you look at the last 7 days, and if someone has gone to 4 or 5 retail locations, maybe a restaurant or 2, and there's no other cases linked to that facility on that date and time, it is very hard to track. So again, that's why general slowing down is what is recommended right now. And then unfortunately, the hammer approach works like it worked in March, but it comes at great cost. And that is the last resort. And I think as much as we can do through the measures we have in place is really the best way. But we need to see our numbers go down. I mean, we really need to see that go down. And again, I had said in December that if you're used to seeing 100 cars in a parking lot, we should be looking at 25 cars. And pre-Christmas shopping, people seem to slow things down. Right now, I think we need to have the same principle. Go when it's less crowded. Be extra diligent about all the precautions. These are the only tools we have collectively that can bring numbers down. And of course, the other option comes at significant cost. Especially if it has to be in place for a long period of time.
Follow-up, Zach?
Yes, I have a follow-up that might be more appropriate for Mr. Miller and Mr. Livingstone. It's a follow-up and just a clarification on the discussion about the supply of vaccine we currently have. I understand you're not looking to adjust your plan at this point, but is that time frame we had of vaccination for the general population beginning maybe in April, is that time frame still in any way realistic, or is it contingent on the approval of more vaccines by Health Canada, for example?
Derek, do you want to take that one?
Yeah, thanks, Scott. We have planning figures for vaccine delivery that takes out to the end of March, and beyond that, it's unknown in terms of what the quantities would be and the delivery schedule. So we're planning based on those numbers, but they don't necessarily represent confirmed deliveries, but it provides something that we can craft a plan and distribution around. So we have that, and that is guiding our work. I will also say, though, that we want to be ready, because we know that there's uncertainties around the supply, and we may get more than what we've been planning on right now. And so we are, across the province, we are achieving a broad posture of readiness, so that we are quickly able to react and initiate delivery of vaccines within 24 hours of receiving them in a local area, and then and quickly work through and deliver all of those doses within a specified time frame as quickly as possible.
Take our next question on the line.
We have Jonathan Guignard with Global.
Hi, this is either for Dr. Shahab or Mr. Livingstone. And excuse me if this is already brought up, but from what I'm understanding is that you expect to run out of the Pfizer vaccine before this next shipment arrives. When do you expect that to run out, and when is the next shipment coming, and is it concerning?
So I'll just clarify, and what the comment was is that we know that we are short Pfizer vaccines based on the plan out to the end of March, where we have an idea of what vaccines are coming, specifically to following up on when we think about the second doses that we are going to require, without knowing what confirmed doses we will see in April. So we will not run out tomorrow, because we do have confirmed shipments coming up. But again, to Derek's point, stuff happens like weather. So today, as an example, we were expecting a Moderna shipment to the province. It's coming tomorrow. And so our team has pivoted, and they'll be prepared to get those vaccines out to the 50+ communities that they're going to Saturday, Sunday, and throughout, to make sure that we exhaust those doses as quickly as we can, as planned. But we're not short, but based on what we know, the confirmed supply to the end of March, when you factor in everybody in that vulnerable group requires a second dose, based on what Dr. Shahab has already pointed out within the new time frame, that's where that number for being short is coming from. So as we learn more in the weeks to come about what's coming in April and May and June, that number will change. Did you have
Follow-up question, Jonathan?
No, that's good. Thank you so much.
Sure. And then time for one more in the room. Adam?
Do we have a goal on how many people we want to vaccinate and basically the end timeline for this? So let's say 80% of the population by September, 95% by October. What's our goal and what are you hoping to achieve?
Yes, so maybe I'll start with some additional comments. So again, obviously, we have 2 safe and effective vaccines licensed in Canada. Early indications suggest that 95% effective in preventing a serious disease. Starting with the highest risk population, I would really look to 100% uptake. Long-term care residents, it's really rare for someone to have a contraindication like a severe allergic reaction or anaphylactic reaction. So if you don't have a severe anaphylactic reaction to any of the constituents, which again is very rare, I would expect 100% uptake in the most vulnerable, long-term care residents, primary care home residents, and for healthcare workers and primary care and long-term care staff, high uptake, because then that's the second layer of protection to existing residents and residents who may be admitted in the future. Moving forward again with vulnerable groups, 70 and older, that is again being opened up right now, and then towards the end of February, March, maybe 50 and older. My recommendation is, unless you have a severe anaphylactic reaction to a first dose, maybe where you may be recommended not to receive a second dose, the vast majority of us should get the vaccine. It provides a very high level of clinical protection, and that is essential for us to come out of this pandemic. And then, going forwards into, May, June, all adults should get it. By May, maybe our COVID case numbers would be really low, hopefully, but that doesn't mean we shouldn't get vaccinated when our turn comes, as, for example, a healthy, 18 to 50-year-old, still go and get the vaccine, because then we minimize any transmission. And of course, at the moment, the vaccine is approved for, 18 years or older or 16 years older, depending on the product. But right now, trials are happening in school-age children, in infants, in younger children, and those trials, the results would be available over the next few weeks. So when we then look at the summer, assuming that the vaccine is approved for use in children and supplies allow in July and August, again, based on the recommendations by NACI, high uptake in children as well at that time, as recommended, would be important as well. And then that will allow us to, come out of the pandemic by late summer.
So just, if I can add, just from a planning perspective, Adam, our plan is that anybody in this province who wants a vaccine will get a vaccine in their arm before September, and that is our plan. That's what we're planning to. So if it's 800,000, if it's 900,000, if it's 1 million people, we will be prepared to do that and have vaccines in arms by September for anybody in the province who can safely have a vaccine, because there are some restrictions right now with the younger folks, but certainly that's what we're planning to.
We know that some sports leagues and other things have been told that maybe they're going to need to hold off on getting back to where they were before the restrictions until at least the end of March. What can you tell us about what these organizations and maybe other groups that have activities where they have to bring people together, gyms, things like that, what your advice is and what you're telling them going forward over the next couple of months, what they can expect?
Yeah, so for sports teams, again, we did see in November and December that there was a high rate of outbreaks in sports teams, and then that was being imported into schools, into workplaces. So unfortunately, while conditioning is allowed, you can go to a gym and exercise, you can exercise outdoors. Competitive play at this point is high risk, not just in Saskatchewan, but throughout Canada. We really need to see our numbers come down before that can cautiously be allowed, and maybe we'll have to look at the guidelines as well. But certainly, I don't foresee that for the next few weeks at least. But that is something that obviously, there's a lot of benefits, psychological, mental, physical. Many young children, they want to make it into their career. So obviously, those are very real concerns. But at this point, and we are in the same boat as many other provinces, it is just something that generates a lot of transmission into schools and workplaces. And then the second comment about when can we have larger people of getting together. Again, we'll have to see. I mean, transmission really has to be extremely low. We need ideally a higher proportion of the population vaccinated. And so those would be considerations about, current public health measures have to continue at least into late spring, early summer. But, is maybe June, July a time when we can look at, if our case numbers are very low, increasing proportion of population vaccinated, how can we start relaxing some of our public health measures, I think will be discussion for that time. And we'll learn more about, how does immunization not just prevent clinical illness, which it does very effectively, but there's now encouraging evidence that it also, to a lesser extent, prevents transmission. So, this combination of, herd immunity through vaccination and the ability to reduce transmission through vaccination allows us to gradually relax public health measures. But obviously that we can only start thinking about, April, May onwards.
Thank you, everyone. That is all the time that we have today.